Well, again, thank you very much for having me in your fantastic society. I want to thank Dr. Farha and the organizers, especially Professor Hassan, for giving me this opportunity. Today, I'm going to talk about transkambin oblique lateral lumbar interbody fusion, a procedure that I have been performing for the last 15 years. And I want to start by saying that this addresses a problem that is a public health issue. In the United States, for the last 15 years, spine has been the number one reason for disability. And worldwide, according to Lancet, it's become number one reason for disability worldwide. By the time you're 70 years old, there's only 2% chance you don't have spine problem. Obviously, many of these patients we help with the protocol, even we have developed, non-surgically. And many of those patients who need the surgery, like if you have a herniated disc, you don't need a fusion. You can address many of these problems without the surgery, and some of them with decompressive surgery, but there's a group of patients that will need fusion. And that number is increasing worldwide. According to Becker Spine, 1.62 million instrumented spinal fusions are performed in the United States annually. And even now, 75% of them are performed in the traditional way. I know when you go to conferences, everybody is talking about MIS, the robot here, navigation there, small incision, and so on. But it's still, the fact is that 75% of the surgery in the United States are performed in a traditional way. So, and I was saying that this surgery is not about the skin incision. What happens under the skin makes the surgery truly minimally invasively. What am I talking about? I'm talking about in a regular surgery, we know we don't reattach all those muscles that you're able to see. And these muscles are multisegmental. In a regular surgery, when you detach the tendon of these muscles, you're practically disrupting the autoregulation of the muscle. Like imagine you get a shoulder or elbow surgery and you don't reattach the tendon. Practically, you're rendering that joint physiologically non-functional. And yet, this is what we do for the spine. And I think this is extremely important. This is from 1930s research. All of us, we know there is no artery of L4 or L5. The vascularization of the bone is through surrounding muscles. And in a traditional posterolateral fusion, where when you strip the muscle of the bone, you are disrupting vascularization of the bone. And how much? Based on this study, 75% of the vascularization of the bone is through posterior attachment to the muscle. So in a traditional T-lift, you're reducing the vascularization of the bone vertebral body to the 25% of the original value. For that reason, all muscle sparing, not only my technique, but all muscle sparing techniques show high 90% fusion, much higher than traditional fusions. This is a patient of mine. In 2012, I did the two-level T-lift, what you see on the left side. On the right side, 2 years later, I did the adjacent segment OLLIF. And 1 year later, patient had a severe car accident. I had to take the patient back to surgery. And as you see, as we know as surgeon, where you did the traditional surgery, everything is a scar. Whereas where we did the MIS surgery, you see actually pristine tissue, well-perfused tissue. By the way, if you pay attention to the bottom of the screw, you see fusion actually happening in the facet right there. Here, the white material here is the bone growing from one facet to another. And I'm going to come back to that, what's important of that. This is an MRI. In the traditional surgery, what you see in the back is a scar. This is the muscle, and that is important as well because this is a one-level L4-5 fusion. A patient of mine, 2 levels above the multifidus muscle has turned into scar. These have impact on patient recovery. Now, as well, the time under anesthesia is very important. Now, let me just come and tell you something that is important for you to understand. Speed is never the goal of any surgery. But in this surgery, speed or efficiency, what I call it, is a byproduct of the surgery. What do I mean? In a regular surgery, you stop the bleeding, you move on, you cut more, you stop the bleeding until you are where you need to be. Here, all of that falls away. As a matter of fact, most of our surgeries, I come back to that, are done in a fraction of what you would need to do open traditional surgery. And that has impact on patient's outcome. Not that you're trying to be fast cutting corners, but you're performing a different surgery that doesn't have all those requirements. This is a meta-analysis of many studies, about 400,000 patients, that shows just the time on the anesthesia translate into outcome. Every additional half an hour on the anesthesia adds 17% to the combined risk of the surgery. And that is for all patients. And that's only anesthesia related. For people who are prone, that actually is higher. Practically, if you put all your patient, or anybody's surgery's patient, all the surgeries that are under 2 hours and put all the patients who are above 2 hours in two different groups, the group over 2 hours, they have twice the risks associated with the surgery and anesthesia itself. Now, we are all familiar with the posterolateral fusion. And again, in the United States, 80% of the surgeries are performed traditional way. And then we are familiar with anterior approaches and lateral approaches. Today, I want to talk about the OLLIF, which is a transkambin approach, is exactly at the border between posterior and anterior approaches. And this is the long path you see here. That is the path we take for so-called transkambin approach. We have published actually 2 more papers since this slide. So last year we published 2 more papers, and we have 13 papers published for this procedure and technique associated with this. And actually this is already the older slide. We have in this slide, as you see, I have alone has done over 1,800 of these cases. So this is not experience based on 30 cases and so on. We have tremendous amount of experience with this, and we have been following this patient for over 10 years. Now, not individual patient for 10 years, but we have 10 years follow-up with this patient. We follow up the patient in average 1 to 2 years, and after that, only when there are clinical symptoms or problems. Now, the results show that about 40% of the surgeries are performed under 1 hour and 95% are performed under 2 hours. That has importance to my practice. This is like a view of a surgical cases in one hospital. These are 2 other surgeons performing ALIF, 2-level ALIF, anterior posterior. You do the anterior part, you break the scrub, you turn the patient, you do posterior. And 6 and 9 hours. About 45 minutes of that is anesthesia time. But in the same day, I perform 2 ALIF, and I'm done by noon, and my surgical times are under 1 hour. And again, this is not specific to me. Everybody who join us go through the learning curve. They're able to perform that surgery in the same amount of time, much faster than I could get to that point. So this is not a surgeon-specific procedure. The efficiency is not a surgeon-specific, but procedure-specific. Now, this is another study in one of this hospital that I have been doing the surgery. As you see, and as you expect, the traditional TLIF with higher BMI becomes longer, and the rest of the complication directly linearly correlates with the time under anesthesia. So as you see, the surgery becomes more complex at higher BMI. As a matter of fact, our societies are recommending not to do any elective surgery for somebody BMI above 40. This has been from NEST, AANS, CNS, and so on. And as you see, MIS TLIF, minimal invasive TLIF, at BMI of 37, in this study becomes more dangerous. Whereas our surgery could perform in this study up to BMI of 47 with the same performance, and the follow-up study, even with a BMI up to 60, because we use a tube, it doesn't matter if we go through 2 inches or 6 inches of fat. So we can perform almost the same surgery. There's some other requirement, and I can show you, hopefully in the future, more studies regarding this high BMI patient. But that is important because all of a sudden you can help high BMI patient that you couldn't help with the previous surgeries. Now, in your part of the world, I would say that the high BMI is not of a big public health issue and epidemic like it is in the United States. But in the United States, that's a big deal. The barely, in some states, half of the population have a high BMI and so on, and that becomes more issue, especially here in the United States. This is another slide that I think is extremely important that shows our patient, 96% of them ambulate within the first 24 hours, so they can go home. In average stay in the hospital, say for a regular surgery for spinal fusion, is about 4.2 days. Our average is 1.6 days, meaning that vast majority of these patients can be discharged, and I'm talking about multi-level fusion on elderly. Just last Friday, I performed 3 multi-level fusion on elderly patients, 75 to 87 years old. All of them were discharged under 24 hours. So this is persistent that we can bring them back on their feet, discharge them faster, they get back to their life faster. And this is just an indication. 96% ambulate within the first 24 hours. In a comparative analysis, only less than 6% of the patient could independently ambulate after 48 hours with a traditional surgery. Now, I'm going to bypass few of this, and that is, I think, what's important in the United States. As of now, less than 3% of the spinal, lumbar, or spinal fusions are performed in surgery center. Vast majority of them are performed in the hospital, and there's a huge number of people, up to 40%, elderly, high BMI, comorbidities, that they need a surgery, but it's not really safe to do surgery. As our society says, don't do surgery for somebody, elective surgery on somebody with a BMI above 40. Our data shows that we can do vast majority of them in the surgery center, and all of a sudden, many of those surgeries that they weren't candidate, they can be done in a hospital. So we can help much more many patients. And this is another fact that I think is important to your part of the world. Whereas when we go to societies, everybody's bragging about a $5 million robot and navigation system and so on, and how much they money spent on that. Just a maintenance fee on one of those machines is about $500,000 a year. This is all you need to do that surgery. As a matter of fact, my front table looked like this. A handful of instrument with learning, obviously, curve that enables you to perform this surgery. When I went to India last year, I had a bag, like a smaller than the bag of my female assistant, and that was all I needed to do surgery on 3 patients in Chennai, in India. So you don't need a multi-million-dollar, machine, complex machine to do the surgery. This is the entire OR look like. Here is my front desk, front table, the back table, and what you see how empty these tables are. In a regular surgery, you see 3 times more of that, and complex retractor system and so on. All of that is really not necessary. And again, this is not specific to me, it's specific to the procedure. So this is practically the way that skills truly compensate for lack of million-dollar machines. You have to learn how to use this instrument, but once you have done that, you can go with a small bag to any small village in a hospital that they have a spine table, 2C-arm neuromonitoring. Those are still issues that we are trying to overcome. But then you're able to perform this surgery. Now, let me just show you the step of a 1-level fusion. And here, obviously, patient has a L4-5 ischemic spondylolisthesis. The surgery starts here, where I'm marking the landmark on the skin. I will show you on a small other video how these steps are. I want you to see this is now 5/16. I start marking those landmarks on the skin. Here you see that, and at about here at 5 19, I put a Jamshidi in one of the levels and draw blood or bone marrow to mix it with my biologic. And here you see the Jamshidi goes in. We have seen that by mixing bone marrow with biologic, that becomes really much more efficient for the fusion purpose. And then I put a K-wire there. Now here is a probe. I will show you that probe in another video. The probe is insulated all the way to the tip with Teflon. The tip is open, and then there is a sleeve, metal sleeve over it. I aim for the pedicle of the level below, as you see here, and then I slide it down to the Kambin triangle. Now, this is one thing that I learned. It took me 180 cases to learn that. Instead of freehand navigating, trying to poke through Kambin triangle, I aim for the pedicle below and slide it down. That alone cut my rate of nerve irritation in half. And that information, it was hard-earned by me having all those higher rate of nerve irritation. Once the probe is in right place, I stimulate at 4 milliamp. In this surgery, you do need neuromonitoring. We are trying to develop a way of having neuromonitoring much more price conscious. As a matter of fact, when I'm going next to India, please come and join us in Bareilly, close to New Delhi. We will have live surgery, we will have demonstration, but as well, we are bringing our neuromonitoring machine that doesn't cost you $50,000. It'll cost you $3,000. And we teach you how to use it and so on. So we're trying to pack everything needed around this surgery to make it successful in the part of the world that the resources are not as plenty as in the United States. Either way, you put electrode in the legs, you're stimulating at 3 milliamp. Once you're in Kambin triangle, you stimulate to 4 milliamp. Then at this point, the sleeves goes in. Then over the sleeve, we take the probe out, the K-wire goes in, and this is now where dilation comes in. You see this anatomy changes when this goes in. Most of our colleagues, they call it indirect decompression. I call it physiologic anatomic decompression. And literally lift it up, open up the lateral recess foramen. And now this is the tube. I will show you a picture of it later. It's 8 millimeter inside, 10 millimeter outside. It literally gives you a path from the skin to inside of the disc. And this is where the magic is. These are specifically designed tools that enable you to do discectomy. I show them to you again. Then after the discectomy is done, I pack it with the biologic. I put a K-wire, and the tube comes out, and then you have a path that you follow a K-wire from outside of the skin to inside of the disc, and that is what you see here. The cage is going in. Now, I want you to just understand these two facts. We started the surgery at 5:19. It's 5:27 down here, if you're able to see that. Within less than 10 minutes, we have already the cage in place. Because we didn't have to go through the traditional steps of cutting, stopping the bleeding, move forward, to remove the bone from the facet, and so on and so forth. And this enables you to really concentrate on the pathology rather than getting there. Now, I will have a lot more information for you later on about the steps, but obviously you need to understand the Kambin triangle. You need to understand complex anatomy that is there and how you can reduce risk associated with surgery. And the instrumentation, what we put together, we call it soft transition, where you learn it like a stepwise. We modeled it like a flight instruction. Now, there's two things that spine surgery and flight instruction have in common. I'm a pilot, and I went through that, is that mistakes are very costly. So you want to reduce the number of the patients who have bad outcome, nerve root irritation, retroperitoneal, complication, and so on. And I think after 15 years, we have packaged it together that it's quite significantly beneficial to the patient. Now, I use 2 Shyam, then I don't have to go back and forth. Just not long ago, one of our society member was doing it with 1 Shyam. In one of the Shyam in the AP, everything looked great, but by the time they went to lateral, the cage was anterior to the vertebral body. You don't have those problems if you have two C-arm. Yes, two C-arm is more resource, but then you can do in the same room 6 surgeries in one day. Tomorrow I will be in Kansas and I will be doing 7 surgeries, 7 fusion in one day. You need two C-arm, but that takes you more, that these resources take you more. And then I'm going to just bypass these steps. I want to show you that you can do discectomy with these specialized tools that I'm going to show you. This is the animation of the procedure. Practically, the Kambin triangle, the patient is then positioned obviously prone. In this video, you see C-arm going back and forth between AP and lateral. I haven't done it for last 10 years anymore. Two C-arm gives you efficiency that is unparalleled. I draw the anatomy center of the disc in the AP and in the lateral view. And then these are things that we teach to our other surgeon in a cadaver lab and in live surgeries. Once we have drawn those lines, we go equidistance and we use a position that takes us at the angle of 45 degrees to the Kambin triangle. Here, you see that the animation takes you directly there. That is a wrong thing. We don't do that anymore. We don't aim for Kambin triangle. We aim for the pedicle of the level below, and then we slide it down. As you see here, you see how it can get you there. And because we have neuromonitoring, if you are too close to the nerve root, you get the signal, and then you have to reposition it. Now, once we are in the right place, I stimulate up to 4 milliamp, and then the sleeves goes down, then the monitoring probe comes out, a K-wire goes in, and then the rest is a dilator. Over the dilator, the working cannula goes in. And then this working cannula enables you to use a series of tools all the way through this working cannula to the inside of the disc and perform your discectomy and end plate preparation. Now, once we get to that, these tools are complex, but they're not expensive. They're really, really not expensive. The most expensive tool is this one, which you can buy it. We are trying to make it possible that India builds it for the rest of the world for a few $100s. These are really not super expensive tools. But they enable you to perform a discectomy, prepare the end plates, and prepare for the next step, which is packing the space with biologic, and then putting back a K-wire, and then put a cage in. Now, what's important here that many of our surgeons that now use this surgery, use these tools as well for open surgery, because the tube that you see there protect the dura and the nerve root, and then this sharp instrument don't have to pass the dura and the nerve root all the time. So as you see here, we package it biologic, and then here you see a PEEK cage. 6 years ago, like most of my colleagues, I transitioned to titanium cage, which is way more efficient and become part of the fusion. But at this point, practically surgery is done. So let's now, I'm going to show these actually videos not here today, but I want you to know that by going this like algorithmically, you can put the cage right and left and correct for sagittal deformity. We published a paper about that we can correct up to 5 to 7 degrees in comparison pre-op and post-op CT. We haven't published our sagittal deformity correction, but the data is very promising. It seems that with the combination of a different technique that we call minimal invasive direct lateral interbody fusion, or practically what is a prone lateral, you can put the cage right at the front of the vertebral body and correct up to 2 to 3 degrees per level in the sagittal plane. Now, I'm going to show you a patient that once you learn this technique, I didn't do that in my first 100 or 500 cases. I did that surgery after I have done 800 cases. But once you algorithmically learn that, you can do complex cases. By the way, Dr. Gasco, who has done maybe 100 cases, 150 cases now, start doing these cases after 80 cases. I start doing it after 800 cases. So we have packed this everything that goes with it in a learnable packages in what we call in soft transition levels, level 1 to level 7, then the surgeon can perform these surgeries much more efficiently, much faster, with much less number of the cases they need to do. So practically, this became this. This is the skin, and this surgery was under 2 hours with about 230 cc of blood loss. All of a sudden, patient like this patient, that 3 other surgeons said she cannot have the surgery. Now all of a sudden they can have the surgery safely, get back to their lives. And that is, I think, what I'm really proud of, that we can package it and teach it to other people. This is, if you have a camera, you can take a picture of it. That scan shows you the actual lab on the cadaver. When I went to Seattle, I gave the lab. And as well, it shows you as well the talk I gave there that present you all the data that I have probably not offered you. We have multiple studies. I'm not going to go through that. I want to give you time and some opportunity to ask questions. But we have a lot of material for learning and teaching. I'm very honored to be with you today. Thank you for this opportunity. And I'm going to just stop here and answer some questions.
Thank you, Dr. Abbasi, for a nice presentation. Before we invite any question, I would like to make some comment myself. But anyway, first, Dr. Asif, for any comments to Dr. Abbasi, please.
Thank you, Dr. Abbasi, for your kind timing for us, because I know you're very much busy. And last time we have talked on the WhatsApp, I invited you on behalf of all the surgeons of Bangladesh to come in Bangladesh, and you have agreed. And hopefully
I'm honored to be there. I'm honored to be there. I just have to really fit this in all my other clinical obligation, but I will be there. It's just a matter of timing.
So one thing I'd like to mention, that important point you have pointed out about the cost of the development of this setup. But as you have shown now, that we can reduce the cost with the minimum instrumentations and with your techniques. So that part we are dealing very much difficulty, because we had some of us have, here is Professor Nuruzzaman is there. He's practicing your discectomy, the transforaminal endoscopic. And we are actually fighting with the instrument costs. So as you've shown, it's very nice because the cost, if it is reduced, then we can build up the centers and we can start the surgeries. And one thing we like to know about the indications of surgery, because every case is individual. So at first, we cannot do all the surgery like you do. You have shown us very easy to do, but I know it's not that much easy. But thank you. But we like to have you in Bangladesh. We can arrange a loss of cadaver and the life surgery. So please give us time and we'll go ahead. Thank you.
Now, first of all, it is truly my honor to be with you. I can tell you something. Your country has a vast history. You are not rich in US dollar, but you have skills. When I traveled these countries all over the world, the way you do what you do is with skills, not with just add another $1 million to your OR. And my work, my life purpose is to give this technology to the people who can put it to good use. And what I'm telling here is that, the set that we put here together in the United States, they cost $30,000. United States, that's not a really big deal. But that is not sustainable for most of the rest of the world. So we are going to try to put something together that is 1/10 of that cost in other countries. But as well, like neuromonitoring is a big deal. No, we just received a machine from China that we are evaluating that enables you and your assistant to run. And that reduces a $50,000 machine to a $3,000 machine. Or we are trying to work on technology to our K-wire. You need K-wires. And I said, we do it, we throw it away. We have now created a path that there is a $30 instrument you buy on eBay, and you put your bent K-wires, you put it through that, it make them straight for you again. So we understand it's not about just, many of the, like in the United States, when I go to these conferences and so on, everybody's proud of their new technique. What they don't say, it just added $30,000 to the surgery. Now, that is not, or that is only sustainable in the United States and maybe a few other countries. But we just talked about that this is a global issue. This is number one reason for disability. And we need to have a global answer for that. And now, what we have developed within Kambin Society, and please, all of you, please join us, be part of it. We need to package how the education should look like around this. And I can tell you, every mistake that can be done, after having done it now, as of Friday, I have done like over 1,860 cases. Every mistake that can be done, I have done it already. So let's not repeat my mistakes. Let's add to my learning curve rather than just repeating my learning curve. And we have packaged it in what we call soft transition. We have created this fellowship program. And one of my pain was that I had this and I wanted to bring people from many countries to the United States to learn that. That is a big deal, not only because of getting a visa and so on, but the United States, you cannot put hand on. You need to have a USMLE and so on and so forth. It takes a huge path to get you there where you can really participate and learn that. Now, I'm proud to say we established, as you see up here, ATU, Avicenna Technical University. Within the next year, we will be able to bring international fellows here. It's a big deal, but we will be. But even before that, within the next few months, we have our fellowship program in multiple centers in India. And I would be proud, I would be honored to create something similar in Bangladesh. Well, you know that, but most of the people in the world may not know that. Bangladesh is one of the most populous countries in the whole world. There's a lots of people who need help there. Okay, so it would be my true honor to be part of that. And my goal is for many of those parts, we donate. As a matter of fact, Avicenna Technical University has a philanthropic part to it that we see it as our goal to make it easy. We donate all our intellectual property free of charge to India. There's no reason India should be the only place that they can build. That brings as well jobs in, that brings as well education in, and so on and so forth. And what I'm getting at is that I would be honored truly to participate to creating some similar path as well in Bangladesh. Now, we have this so-called soft transition. Dr. Farha is very familiar with that. She will share all the steps of this soft transition with you. It's a very structured way of learning, and it is modeled after flight. There are two things. I'm a pilot. I went through piloting training. There are two things that the piloting training and spine surgery have in common. It is very unforgiving. If you do mistakes, the results are really bad and are immediate. Like, I'm just going to tell you, one of our surgeon that just went through thing, but not through soft transition, using one C-arm. And then in the AP, everything looked perfect. In the lateral, by the time he went lateral, the cage was in the abdomen.
Yeah.
Okay, so there is a reason we do everything, and you don't have to repeat that. You can just learn it. This is the fact. People who joined the soft transition, after 10 cases, they have it's so much experience that I had after 180 cases.
Okay.
So, and that is the whole purpose of the Avicenna Society and ATU that package that, the learning point, and I'm going to go to close to New Delhi in a city called Bareilly with Dr. Varun, who is a co-chair of the Kambin or Avicenna Society now, that we established the fellowship program. All what we need, the commitment that once you learn it, you teach it to other people. That's all what we ask from you. And we bring
Yeah.
as many resources as necessary to make you successful in this. And then I'm hoping that then your university and my university, ATU, we make this cooperation that for selected people, we bring them here. We teach them how things are done here in the United States. Not everything we do is good here. I guarantee you that. And the last year, politics shows that not everything we do is good. But we can learn from each other a lot. And part of that is we come to you, but part of that as well, we bring you here. And so I'm inviting you all, if possible, we send you invitation. Please come here, be my guest. Let me show you how we do think here. But more important than that, let's learn how we can replicate that in your place.
Thank
Thank
you.
you.
Is Dr. Rezaul Karim, are you there? No, I think he has left. Dr. Nuruzzaman Khan, Professor of Neurosurgery, your comment, please, Khosru bhai.
Thank you, Professor Abbasi.
Faizul, I am available now.
No, Reza bhai, sorry. Okay. Reza bhai,
Okay.
please, you comment first, and then we'll go for Dr. Khosru, please.
Oh,
Dr. Rezaul
thank you,
Karim, Professor
Faizul.
of Spine Surgery, Bangladesh. Hello. Oh, there's some technical issue.
Well, it is very interesting. My middle name is actually Reza. My full name is not Hamid Abbasi, it's Hamid Reza Abbasi. So I think that I have in common with Professor Karim. That
Reza bhai, are you there?
I think Khosru is here, so he can
Khosru
start.
bhai, please.
Thank you, Professor Hamid Reza Abbasi, being with us. It's our great pleasure to be with you in a conference. Actually, I invite you in our ACNS interim meeting, that is Asian Congress of Neurosurgical Surgeons and Bangladesh Society of Neurosurgery, jointly organizing a conference. I invite you at that conference which will be held in next month. But unfortunately, we are not able to get you in this conference because you have the tight schedule, and you have another conference in India in next July, I think so. And in that conference, I am also faculty, so I think I can meet there with you. And
my honor.
definitely in near future, we will try to honor you to get in Bangladesh, and wish to see your medical surgeries and life, as well as cadaver workshop. And we will definitely try to organize this conference with you. And you already I know that your surgery is totally CM dependent as well as neuro monitoring dependent, and you prefer not to use endoscope, and that is your strategy, or that is your medical surgery. And we do surgery with Kambin surgery, there is transfemoral surgery with endoscope, and we can do it with local or epidural analgesia. So neuromonitoring is better if it is not possible, if we do this surgery with under local anesthesia, that can also we can monitor the patient to avoid the exiting route injury, because this surgery, the main problem is to injure the exiting route. That is the only issues here. So this is very important to monitor it either with neuromonitoring system, or if we have not neuromonitoring, we can do it with local anesthesia so that we can monitor the patient. But the problem is there, if the disc height is very low, That is very important because the must low the disc side, the risk of injury of the exiting root is very high. So it depends upon the expertness of the surgeon. When anybody become Hamid Abbasi, then he can do everything. But when anybody is a beginner, definitely you have to think twice or thrice to do this surgery. So
yeah, you have
definitely
mentioned.
this.
I apologize. Go ahead.
Yeah. So this is very important issues. And again, I thanks Professor Abbasi, and I will invite you, inshallah, in future in Bangladesh.
Inshallah.
Thank you.
Well, you mentioned so many important points. Number one, endoscopy. I did use endoscopy, and the version of the procedure I do now, this procedure I call it OLLIF, oblique lateral dash posterior lumbar interbody fusion. There's a version of this surgery called KLIF, transkambin lumbar interbody fusion. That is the so-called, at least in the United States, the full endoscopic version of this surgery, where you go and visualize the nerve root. You are making sure you don't poke through it. It's a KLIF procedure. And many of our colleagues, Dr. Vasavada, for example, is a master of that in India, the endoscopic version of it. Or my good friend, Dr. Varun Agarwal, who is a master of this technique, he uses the awake technique. So you are doing neuromonitoring, but not with a machine, but by having the patient awake, that if you're too close to the nerve, patient will literally tell you that you're too close. Now, the reason I stopped endoscopy because I saw that with neuromonitoring and double C-arm, me just visualizing didn't add any clinical value. Literally, I did in a dozen of patients with endoscope, and without, in another dozen without endoscope. I didn't publish that data, but it did not add any additional better outcome to me, but it added like an hour to the surgery. So that is why I don't use that anymore. But it's a very valid way of going there, looking at the Kambin triangle. As a matter of fact, the Kambin triangle is this obviously defined by Dr. Parviz Kambin, who was another Persian here in the US, who put a urology endoscope there, and he saw that you can visualize that place because it is the retroperitoneal space, and you can see the nerve root. By being able to see it, you can avoid it, injury to it. That's all what it is. But the way I visualize the nerve root is that I put electricity on my probe, and I make sure that my electrodes in the leg, they tell me how close or not close I am to the. We have done those studies. I go at 3 milliamp, but once I'm in place, I go to 4 milliamp. But if you're at 3 milliamp, you are in average about 4.5 millimeter away from the nerve root. If you are at 4 milliamp, you are in average about 5 to 6 millimeter away from the nerve root. As we know, the nerve root, I want to show you maybe a picture of that. The nerve root is attached to the pedicle of the level above. And by us hitting the pedicle below, sliding in, we stay away from that. Now, you have another thing very important. In a collapsed disc, it is important that that was one of my major worries about a collapse. How collapsed is it that I say, no, this is not a good candidate anymore? I want to share this video with you. Please bear with me. Here is, you just go to YouTube. The way I described it, I put impossible OLLIF so I can find it easily. There's nothing about that is impossible. But then you see two videos. I want to share both of them with you here. This one, you see how collapsed that disc is? Now, the idea is here, you go with the probe, here is the probe, and once you are in place, you stimulate at 4 milliamp, and then you put a K-wire, and then once you dilate, see what happens. Here, look at that. It opens up the space, and once you have the cage in place, look at that space versus this space. This is the cage without cage, and I'm going to go back and forth. You see how much it opens the foramen and lateral recess. What we could find out, once you have a cage there and you put a dilator, and the dilator opens up the space, it pushed the nerve root north or cranially because it is more or less with some connective tissue attached to the bottom of the pedicle. And the rate of nerve irritation, this is what I found the hard way. The rate of the nerve irritation is, obviously L5S1 has the highest rate of nerve irritation, at 3 times more rate of nerve irritation than other levels. The second is the number of the passes you do. Like if you pass more than 3 times below the facet, you are almost doubling the rate of nerve irritation. The third important factor in the nerve root irritation, if the patient has neuropathic pain, the best indication for that is if the patient who have been on Neurontin, in the United States we give Neurontin if somebody has neuropathic pain, those patients has almost 2.5 times higher rate of nerve irritation. It makes sense. The nerve is already irritated. It doesn't take much to make it even push it over. The size of the cage had something to do. I would have higher rate of subsidation, but surprisingly, I was totally surprised. My rate of nerve irritation wasn't higher or wasn't significantly higher. It was like the 1.2 higher, but that wasn't statistically significant. So surprisingly, even in many collapsed discs, and I want to show you another video, the size of the disc or the collapse of the level surprisingly did not correspond to rate of nerve irritation. Here you see not only that, look at that, this is completely collapsed. As you see, I use actually the osteophyte to get in, and then I put the cage eccentrically to correct for coronal and deformity, but as well you see how it's lifting that space up. We did the studies because once you increase the interdiscal space 2.5 millimeter, you have increased the interpedicular space 2.5 millimeter, and that actually in the average, in the United States average is 70 kilogram person, it doubles the area because it's R squared. It doubles the area of the lateral recess and foramen. For all practical purpose, in vast majority of the cases, that is enough to perform, to achieve the decompression of the lateral recess and the foramen. And another thing you said that I thought is very important is the indication. Now, I need you to understand, number one, this is not going to replace all your tools in your toolbox. This is not going to replace all of them. It's just another tool that enables you for lots of patients to be more efficient and less risky and more put them through the OR in a much shorter period of time. One last thing that you said, and I feel honored you said that you know, not everybody's going to be Abbasi, but what I'm going to try to convince you, anybody can do what I do in much shorter, with much lower number of the cases, and we have studies. We follow everybody who joins us, we follow their number. I want to prove to you, hopefully successfully in the next 6 months, that anybody can do what I do. It's not Abbasi specific. I just have a lot of numbers behind me. I have done 1,860 cases, but anybody after 100 cases can do cases that I did after 1,000 cases, and that is a proven fact. But I feel honored, and I hope I can be part of that with you.
Dr. Abbasi, thank you again. There's 2 questions and one from the panel member also. Do you use the expandable cages in these scenarios? Is it any benefit of using the expandable cages? Number 1. And the second thing is that when do you decide for an indirect decompression rather than a direct decompression?
Both are extremely good questions. Now, number 1, if somebody has osteogenic stenosis of the spinal canal, this procedure is not the right one because you cannot do nothing about it. If somebody has significant facetogenic stenosis that goes to the midline, that is not a good situation. Surprisingly, that's why I get CAT scan on every single of my patients. Surprisingly, even if they have a severe canal stenosis, but it's not the bone, but the soft tissue, it has been very successful to overcome that. Now, one of the best clinical tests is for my patient is that you ask the patient if they lay down or sit down, if the pain goes away. And in those group of patients, it has been extremely successful. What am I doing is very trivial. I change the configuration of the spine that even when they stand up, the configuration of the spine is as similar as when they are laying down and putting no pressure on that segment. Now, there are lots of other factors that we consider here, but in short, yes, you are absolutely right. This is not a surgery for every single case. And I think I apologize. Your first question was something about
expandable cage. So, yeah.
No, I used probably 3 dozen expandable cage, and I regretted every single of them. Not every single of them, but I regretted probably 90% of them. Why? These expandable cage they have a sub-millimeter, 0.5 millimeter pin and screw system to expand that. When you really need that, meaning that you have to put too much pressure, almost more than half of them failed. Literally, that pin broke because it couldn't provide that kind of things. And then the space inside is filled, and I cannot fill it with biologic, and it adds complexity without really any benefit. Now, expandable cage, they have a huge advantage and so on, but I'm talking about you have to provide tremendous amount of force on a small surface. Either it broke the cage or it broke the end plate in my hand. Now, in certain group of people, I have actually that I think I'm going to share my screen again with you. And again, let me tell you another thing. Do you know how much those expandable cage cost in the United States? Let me tell you. A regular cage costs between $2,000 and $4,000. An expandable cage costs $8,000 in the United States. Even for us in the United States, that is tremendous. Okay? So we came up again. That is sometimes you need that though. How do we overcome that? Let me show you a technique that you can use tomorrow in your place. Let me show it to you. You just go there, you put OLLIF in side 2 rotation. It's right on YouTube. So here, what we do here is literally, let me go another bigger thing here. Here, let's try that one. Now I want to have a bigger screen here so we can look at that better. Okay, it doesn't matter. Let's use just any of them here. So I go in the lower profile. Once I'm in place, I turn it 90 degrees. You can do it only with titanium cage with a good connection. But let me go to another one. This is not the best presentation, but here, as you see here, I go in the lower profile and then I turn it 90 degrees. So practically, I made a static cage to expandable cage by going with the lower profile of this cage, which is 9 millimeter, and then the cage height can go to 15. So I can go from 9 to 15. There are certain considerations. Number 1, how hard is the bone? Number 2, is it really worth it? Number 3, how much do you expand? Do you go from 9 to 12 or do you go from 9 to 15 and so on? But as you see here, look at that foramen now. Look at that foramen. That foramen is huge now. And by using a regular cage, going the lower profile and then expanding it, all of a sudden I don't have to spend the additional $3,000-$4,000, and I can pack inside of the disc completely. I'm not relying on those sub-millimeter pins and so on. Now, having said that, those expandable cage, when you go with the ALIF or with the XLIF, are very valuable. The footprint of those cages are so ginormous that you can really use that pressure and so on. And because the cages are so huge, you're not relying on sub-millimeter screws and pins and so on. But for this purpose, for even expandable T-lift cages, I've come away from that, and I'm very happy I've come away from sub-millimeter pin and mechanical system. They didn't really work in my hand.
Thank you. No, it's a very valid point. The T-lift, the surface area of T-lift cages what he used is not big enough. But the XLIF and ALIF have got a big footprint that can sustain the pressure. Okay, it's almost going on. Dr. Rezaul Karim, I think you're back. Any comment, Dr. Professor of Spine Surgery, NITO? Raja bhai, are you there? Oh no, he's it's gone again. Any question to Dr. Abbasi for any of the members, please?
Yes, Faizul.
Oh yeah,
No,
yes. Any comment, Raja bhai, please? We are keeping.
But living
Any comment, Raja bhai, please?
yes. I am lot of things I just learned from from Abbasi. So my comment is, in our Philip and Philip, OLLIF and OLLIF is seldomly done in our country. So somebody, our junior, they are trying to do the MIS like Philip and Philip. OLLIF is our country. OLLIF is nowadays not so much much more by our surgeon and also me. So for our junior, my request to Faizul and Abbasi give some fellowship training for our juniors for their learning MIS like OLLIF. There are taking one of topics given by Anum. It is Kambin approach. It is a very much safer approach, I think. So my request, Faizul and Abbasi, Hamid Reza Abbasi, like he is very experienced surgeon. So my request for my junior, you have to make some fellowship for juniors. Thank you again, Faizul and other speaker and other participants and other faculties. And good night.
Thank you. Thank you, Elizabeth. Dr. Abbasi has already kindly agreed that he is open for fellowship. And in our hospital, we are an AO Spine Center. People from all over the world comes for short to long-term fellowship. But still, we don't do OLLIF, but with the MIS, TLIF, and any aspects of spine surgery, please, anyone interested, please contact me, and definitely we'll try to accommodate in due course.
Well, first of all, thank you so much. I'm really honored to be part of this process. It is, and Dr. Farha has done a great job to organizing that. And Dr. Farha, you have my absolute commitment to set it up this year. And I will come in and for the initial cases, if it's allowed, I'm happy to come and do surgery with you in your place and pass the knowledge. And I will commit as well that go to the device company and get their instrument. I can make them to donate for a certain number of the cases, actually the hardware, to come to you and do the surgery for you. But this is just a short-term thing. The long-term thing is to bring the entire technology to your place, make you self-sufficient, because again, when I went to India last time, I had a bag smaller than Amanda's bag. And in that bag was everything I needed to do 3 surgeries on 3 patients. You don't need extraordinary amount of supplies and so on. So my goal is for you, at least at the short term, to commit to a meeting in Bangladesh, but as well, we are hopefully by June, we have established our fellowship in 3 locations in India. Now, maybe we can train the first few resident and junior surgeon in India, but then establish the center in Bangladesh. but as well, hopefully within 2 months, I'm told within 2 months, the supplies will be available with the price range that is acceptable to the rest of the world. And they're not American produced things that are practically inaccessible to the rest of the world. But you have my absolute commitment to be part of that educational path. And I was just saying, Professor Karim, that you and we have one thing in common. My actual name is Hamid Reza Abbasi, not Hamid Abbasi.
Hey, thank you.
Okay. With this, thank you for all the participants, and again, thank you for PHA, and a special thanks to Dr. Abbasi, Dr. Reza Karim, Professor Khoshu, and Professor Asif for joining, and all the participants will join. Definitely, we'll try to keep organizing this kind of a webinar through the PHA, and also for any live surgery or cadaveric workshop through Abbasi, and PHA will be happy to involve organizing those workshops. Definitely, Khoshu Bhai, he's one of the leading member in the Neurosurgical Society. Definitely, with his help and blessing, definitely we can organize various things in Bangladesh for transfer of technique and technology from the Western world. Thank you very much all, and have a lovely night, almost midnight now.
And one last thing, if I may add, is that Dr. Farha, please work with Amanda. For any member who would like to come and visit us,
yes, sir.
We will provide invitation, and ask Amanda for our Bangladeshi members to waive all the fees, please.
It's so kind of you, Dr. Abbasi. Definitely.
You guys have a great evening, okay?
Thank you.
Thank you very much.
Thank you, Professor.
Thank you.
Lot of thanks,
Thank you. Bye-bye.
Hamid Abbasi, from our Bangladeshi people. And good night from Bangladesh.
Thank you, everyone.
Khoshu. Thank you, Asif.
Thank you.
And thank you, OrthoTV, for streaming the seminar.
Thank you very much.
Thank you, Hassan sir. Thank you, Poonam ma'am. Thank you, Ahmed Abbasi sir. Thank you, Farha.
And still thank you, Nasifa, for hosting the event.